Hello, welcome to FCOM 2021 virtual discussion of otology, surgical options, and diagnosis. I am Mark Wydick. I am a practicing otologist and otolaryngologist in Boca Raton since 1994. Prior to that, I trained at a variety of schools, growing up in Florida in Cocoa Beach, and went to Cocoa Beach High School, followed by Davidson, FSU, University of Florida, and finally Vanderbilt, where I did my otology and otolaryngology training with a fellowship in otology under Mike Glasscock, a fairly well-recognized ear surgeon and a great mentor. I have nothing to disclose that would affect the content in this lecture. So what are we here for today? I'd like to just share with you some of my thinking and just briefly outline what is a surgical option in otology. There are many options that have gradually expanded as our technology has improved, leading to surgery for infections, tumors, perforations, hearing loss issues, including conductive hearing loss and sensory neural hearing loss with implantable hearing devices, most notably the cochlear implant. The decision to go to surgery is often complicated. Some issues, the most simple issues, are when there are tumors or life-threatening issues. These seem like the most dramatic, but in my opinion, they are actually the simplest because there's really no question about the surgical need. The most common example that I have is cholesteatoma. Cholesteatoma is a benign growth of the middle ear that, if left untreated, results in progressive destruction of the middle ear and can eventually lead to severe case of mastoiditis, brain abscess, and death. So that's an easy one. I tell my patients, you either get a cholesteatoma removed or you have the risk of these, very horrendous complications. So most everybody agrees. Where it's a little less clear is perhaps where it's a hearing issue. And the decision as to whether or not to stay with a hearing aid or a cochlear implant, as in this image here. This is a surgical procedure for placement of a cochlear implant, this is an older image. The implants don't quite look like this, but essentially they all have a tail with some electrical stimulators that can be inserted through the mastoid into the cochlea of the ear. You can see this patient here. This is a right ear, and this is the mastoid defect. We also have surgery for ventilation issues with placement of tubes and reconstruction of tympanic membranes for perforations. There are other issues that we do treat. There's otosclerosis, which is an inherited disorder in most cases, where the stapes bone does not function properly and hearing is attenuated just before it enters the cochlea, and a benign tumor of the auditory nerve known as an acoustic neuroma. And it's important to think about acoustic neuromas whenever a patient has long-standing asymmetric hearing. The acoustic neuromas, fortunately, are almost always only in one ear, except in the congenital neurofibromatosis diagnosis, which fortunately is quite unusual. And so a dramatic difference, or even just a 10 or 15 decibel difference in 3 or more frequencies, should lead to an MRI scan, as it is the most effective means of diagnosing the acoustic neuroma and make certain that treatment is appropriate. So hearing loss almost always caused by noise exposure if it is sensory neural, but there is conductive hearing loss, and we're going to go into the distinguishing features of these two types of hearing loss. So conductive hearing loss is brought about by problems typically in the outer or middle ear. The outer ear can cause conductive hearing loss most commonly by blockage from cerumen. Infection can also result in loss of hearing in this area and should be very evident on examination. Problems with the middle ear, including perforations and ossicular discontinuity, can also result in this type of hearing loss. A fairly unique treatment for this type of hearing loss is the BAHA, or bone-anchored hearing aid, which is a device illustrated in this slide that features a small abutment that is passed through the skin with a titanium screw into the skull, which is osseointegrating, so that when I insert it, it goes in very easily, but after about 3 months of time, if you were to try to back it out with the tool that you put it in, it just won't come out. And that's because the bone can grow directly into the titanium and creates a union that is very, very strong. Once that's occurred, we can attach this external processor and vibrate the bone directly, which is then picked up by the inner ear structures and can result in hearing when a hearing aid can't be worn. And that is when there are excessive infections, perforations, or other anatomical issues, say malformation of the external auditory canal, where there may not be an ear canal. The bone anchored device is perfect for rehabilitating a microtia. Another surgical implantable device is the cochlear implant, and it treats completely different type of hearing loss. This is when the inner ear cochlea has stopped working. It could be thought of as a bionic cochlea. The cochlea transfers vibratory sound into electrical stimuli, which can be picked up by the auditory nerve and sent on to the brain. That function often is lost as people age or due to some congenital inherited disorders. When that happens, the cochlea can be simulated with the cochlear implant, and the vibration transfer is done electronically, and the electrical signals are carried through electrodes on the inserted portion. And fortunately, the cochlea spirals around the auditory nerve very closely, and we can drive electrical signals right into the nerve, stimulate it, and patient will perceive hearing. It can be very good today, and speech discrimination scores without the implant are often in the 20 to 30%, and with the implant off 80, 90, even 100% in some very good users. And so I find that the cochlear implant is an excellent way of dealing with hearing loss that is no longer amenable to standard hearing amplification through hearing aids. Another type of surgery that, or condition that is amenable to surgery is perforation. Perforations can be closed nearly 90% of the time, regardless of the size. So if you go from a very small perforation as here to larger perforations, that really doesn't impact very much on the success of the surgery. And I would quote any of the ears in this grid, a 90% success rate with a tympanoplasty. Tympanoplasty is done by taking tissue from the patient and placing it, in most cases, beneath the tympanic membrane and supporting it with some kind of absorbable protein support, either gel foam or fibrin, and allowing the graft to heal into the spot that's missing and reconstituting a normal ear. That's referred to as a tympanoplasty. So the indications for tympanic membrane perforation closure or tympanoplasty include persistent perforations. We always give it a chance to try to heal. Even a large perforation that's traumatic, I've seen complete absence of the tympanic membrane after, say, a lightning strike to a patient's head healed perfectly, which shocked everybody. And no pun intended, that it healed as well as it did. In other frustrating cases where not much more than a pinhole will refuse to close. So size of perforation has very little to do with the rate of, at least of initial closure. Laryngoplasty refers to a simpler procedure where some kind of external graft, usually a piece of paper, is placed over the perforation, which does have the advantage of temporarily closing it. The patients will quickly realize how much of their hearing loss is due to the perforation, and sometimes will also help it close permanently because it acts as a scaffold. But a better repair is most often obtained with a tympanoplasty, where a tissue graft is placed into the middle ear and up above the undersurface of the perforation, resulting in much higher closure rates. Currently, I'm involved with a study where we are evaluating some epidermal growth factors, trying to close perforations in the office with a substance filling the ear canal. Cholesteatoma is a very serious complication of ear infections and eustachian tube dysfunction. This is known as an attic cholesteatoma because it's up above in the attic region, but it's extending under the tympanic membrane. And it's this ugly area right here with keratinaceous material around the head of the malleus, into the attic, and into the middle ear, where you can see this white extension of it behind an otherwise intact pars tensa. Otosclerosis is an inherited disorder where the stapes foot plate becomes fixated. There are different ways of fixing it. And I always recommend that the patient try hearing aids first, because there is rare but serious complications with this surgery about 1 or 2% of the time, where sensory neural hearing loss can be caused by the surgery. Even uneventful surgery can result in loss of hearing in 1 or 2% of the time where a hearing aid wouldn't work. So given that, I always recommend patients consider hearing aids before scheduling surgery. I don't require it, but I try to encourage it pretty strongly, because if they end up with a hearing loss that's permanent and they haven't tried that, then they're going to look at themselves, and I'm going to look at myself and wonder why we didn't try that first. And finally, I think this is the last topic, is acoustic neuroma. This is a large acoustic neuroma present in the right, and radiology always right and left by standard. This is the right ear, and it's a benign, although aggressive growth growing on the auditory nerve and extending and putting pressure and deforming the brainstem in this case. And it can be serious and life-threatening, because eventually the brainstem compression can occlude the normal drainage of the cerebral spinal fluid and result in herniation of the brain. So a large tumor like this, unless it was a very elderly patient, most people would consider surgical excision. Stereotactic radiation is also an option, and this in certain circumstances might still be a radiated tumor. In smaller tumors and in younger patients, well, patients of all age, if the tumor is not growing, then it doesn't need any treatment. And I recommend most patients repeat an MRI scan after 6 months of first diagnosis, just to be sure that it's not stable. An acoustic neuroma may not grow for many, many years, may never grow. And if that's the case, then no treatment is necessary. It's nothing about the tumors are malignant. They don't cause problems except where they are. And so if they remain fairly small, we can often avoid treatment altogether. So with that, I thank you for participating in this event. We will have email information available. And if you have a question and you're not attending the live event, feel free to reach out to me. It's mwidick@entaaf.com. Again, MWIDICK@entaaf.com. Thank you.
Hello, everybody. My name's Jed Grissel. I'm an otolaryngologist in Wichita Falls, Texas. Thank you for joining this discussion today about multidisciplinary hearing care in a modern age. And I'm joined today with Dr. Jill Davis. She's at Victory Hearing and Balance in Austin, Texas. And so we're happy to be co-presenting this topic and talking about hearing loss and cognition in our practices. And I'm going to go ahead and give the first few minutes, and then after I give my part, then Dr. Davis will come on and she'll kind of round things out for us today. So we'll go ahead and get started. So this is me. I'm an otolaryngologist in Wichita Falls. I have a clinic that is a general ENT clinic with 6 physicians, 2 nurse practitioners, and 5 audiologists. And we do comprehensive otolaryngology with cochlear implants and hearing other types of hearing technology. I also own a clinic that does retail vision and hearing in the Dallas area. These are my disclosures. And so today we're going to talk a little bit about why it would make sense for an ENT/audiology clinic to include cognitive screening or assessment of cognition as part of their communication needs assessment or hearing aid evaluation. What is what we call it. Secondly, we're going to talk a little bit about how does cognitive screening in the ENT clinic fit into sort of the greater cognitive health ecosystem. Where do we fit in terms of those who are caring for cognitive health? And so I think to start this discussion, it makes sense first to recognize that we all know that the hearing industry is changing, right? So as innovation and technology sort of is poured into the hearing space, we see this continue to segment, right? So we have on the low end of sort of the experience paradigm is sort of the direct to consumer, lower cost, but also lower expertise and experience. And then you move sort of up this chain to what we consider ourselves as sort of the medical model, where we have a more comprehensive diagnostic and treatment options available to our patients. And as this market becomes more crowded, I think it's very important for us to realize that we need to continue to innovate in the way that we assess and treat hearing loss in our practices so that we can maintain and differentiate ourselves at the top end of that model. And so I think that this is one example with cognitive testing in our practices of how we as hearing health providers can continue to differentiate ourselves and provide sort of a unique experience for our patients and thrive in the environment that we exist in today. And so that's one of the reasons why I think that this is valuable for our practice. And so today we're going to talk a little bit about some of the top reasons why cognitive screening belongs in the hearing aid evaluation or communication needs assessment. So the first reason is that we know that the audiogram, we have known for decades that the audiogram alone is not enough to give us a full picture regarding somebody's communication needs, right? That audibility, there's more to communication than audibility. And while the audiogram gives us some information regarding that, it does not give us other important information. So in our practice, a comprehensive communication needs assessment does include traditional audiometrics, but it also includes quality of life assessment, speech and noise testing, and then cognition. And so we feel like that these other domains of communication help us to be able to provide a much more complete and holistic picture to our patients about what's going on and differentiates us from the experience that's going on with other patients. And so, and Dr. Davis will show examples of how she is doing this in her practice, but this is a patient-facing document that we've created for our patients so that when they come into our clinic and leave, they are given this information which shows how they are performing in these different domains. So in the center panel, you can see that we have sort of translated the audiogram information into a more digestible format for patients to let them see how well their ears detect sound. On the right side, we have sort of like a panel that discusses what is the impact of hearing in their life. So we have a quality of life assessment, which is the HHIE or HHIA that we're using, a speech discrimination score for how well the patient's hearing in quiet, and then how well they're hearing in noise, we're using a quick-syn. And so the right panel is sort of like hearing the impact of hearing loss in the patient's life. And then the left-hand side is how well is the brain performing tasks that are required to be able to process sound. And so that's where we bring in these different aspects of cognition. And so we want our patients to be able to really understand this and see why an intervention is necessary or will be helpful for them. The second reason why we've included this is that hearing in noise matters to our patients. If you think about why patients seek us, hearing health professionals, typically it's not because they can't hear pure tones. I've never seen a patient come in and say, I'm missing, pure tone recognition at 500 decibels. They come in because they can't hear at church or at a restaurant, and hearing in noise is a key driver that drives patients to our clinic. And we know that understanding speech and noise requires more than just audibility. It also requires intact cognitive skills to be able to actually process that sound. And therefore, a more comprehensive approach to assessing communication needs also helps us to be more responsive to the things that bother our patients and matter to them. This is an example of a few case studies or clinical examples of how we are using this in my cochlear implant practice. Dr. Davis will show us more of the hearing aid side. And so what we are noticing is that when we talk to our patients about how they're going to respond to the cochlear implant intervention, we've learned that we're pretty darn good about improving audibility. A cochlear implant, regardless of what the patient's doing, they're going to be able to detect sound better. But the question is not every patient is going to be able to improve the same in terms of how they perform in speech. And so this is an example of a few patients and how they performed preoperatively with their cognitive skills test, and then how that translated into their improvement in quiet versus their improvement in noise. And what we're finding is that if a patient has if you look at these first two examples, these patients scored greater than 75% in all three different cognitive health domains or cognitive skills domains preoperatively. So they had intact, good functioning cognitive skills. Those patients that had that preoperative ability improved tremendously in quiet, looking at their percentage improvement in CNC. But then we also look at their hearing in noise, and they also improved significantly on their ability to hear in noise. Conversely, the patients who started off with a poor preoperative cognitive skills, if you look at the two patients at the bottom, we still improved those patients in terms of their ability to detect sound and quiet, but their hearing in noise is not improving as well. And so we are using this on every single patient to be able to help us differentiate those patients who we really are going to need to focus on. The patients that we may need remote mic technology or oral rehab and that sort of thing. So this is becoming a critical part of our preoperative hearing assessment, our cochlear implant candidacy assessment. The third reason we've included this is that bringing cognitive screening into the discussion, into the debate with our patients really changes the discussion. We know that nearly all patients are concerned about poor cognition, and when we measure this cognition and discuss with patients about the ear-brain relationship, it really helps them understand the value of treating their hearing loss, which in turn results in improved conversion rates and for our practices. This is a quick study that was performed, a survey that was performed by the Alzheimer's Association, which just showed that they surveyed different generations of patients and asked them which health problems bother you or concern you the most. And nearly every generation, or not nearly, every generation viewed Alzheimer's disease or dementia as a health problem that was high on their worry list. Even more worrisome to them than cancer, stroke, heart disease, diabetes, or arthritis. And so we know that when we bring this hearing loss, ear-brain relationship into the discussion, we're really tapping into a thing that touches a nerve on all the demographics of patients that we see. So we're actually responding to the needs that they have or the concerns that they have. And then the other reason to discuss here is that as hearing professionals, we can play a very important role in the cognitive health of our patients and in the delivery of cognitive health in our communities. We know, for example, that there are many health problems, take away hearing loss, but many other health problems that can present with poor cognition. For example, suprathreshold listening disorders, such as ADHD, auditory processing disorders, and some of those other suprathreshold listening disorders, but also general health problems. For example, sleep apnea, depression, thyroid disease can actually present as mild cognitive impairment, which is detected on our screen. And finally, polypharmacy affects millions of Americans, and this polypharmacy can cause cognitive impairment and also can result in tremendous economic and damage and comorbidity for our patients. And so this is an opportunity we need to ask ourselves in the hearing health community is, what role should we be playing, since we don't diagnose, it's not in our scope to diagnose and treat these problems, but still, what role can we play in increasing awareness for some of these issues? So this is an example of something we developed in our practice that helps us communicate with our primary care physician colleagues. If we have a patient whose hearing loss has been properly treated and their cognitive skills remain poor, we reach out generally to the primary care physician first, and we send them this letter that explains to them that we've included cognitive screening as part of the patient's workup, we've treated their hearing loss, and it's persisted, and these are some health problems that could be considered. And so we talk about the diabetes, heart disease, depression, kidney disease, sleep apnea, and thyroid disorders, as well as a list just to remind the physicians of what types of medications could be causing cognitive impairment. And that's what we do. And then if the primary care physician addresses these issues and this continues, then probably the next visit would be neurologist or neuropsych. So the question then is, how does cognitive screening in the ENT and audiology clinic fit into kind of the greater health ecosystem? And these are some of the sort of devil's advocate comments that I've heard in the past of, as ENT doctors and audiologists, we're not cognitive health specialties. It's not in our scope of practice to be diagnosing and treating these problems. We still have a lot of data that still is forthcoming about the long-term impact of treating of dementia development by treating hearing loss, and that is certainly true. And also, when a cognitive deficiency is identified, what do we do about it? Who do we contact, and how do we manage that? And so I think it's useful to think about this in terms of what I call the blood pressure paradigm. And decades ago, we as a healthcare community decided that blood pressure measurement is a useful biometric measurement that we use as a surrogate to help us think about the patient's cardiovascular health. We recognize that their blood pressure may change from day to day, depending on if they're nervous or if they've been exercising, but we still use this as a surrogate to help us determine that patient's cardiovascular health. Many professionals that are not cardiologists measure blood pressure, and they use this as a screening tool. They use this to help them decide how the patient's responding to interventions such as, exercise or dietary changes. And then if there's an issue or problem, then they refer that patient to the appropriate cardiovascular health professional. Similarly, cognitive screening can help us learn very important information about how the patient is performing from a cognitive health standpoint on that day. We do recognize that the cognitive skills, their scores can change from visit to visit. And so we have to look at trends and how patients are responding, but it still provides valuable information. And it also gives us information of how the patient is responding to interventions. And so this is an example of a patient of ours that we recently implanted, 51-year-old female who had a unilateral CI bimodal daily use. And you can see that preoperatively, her cognitive scores, especially in memory and executive function, were poor. And then 6 months after 6 months of cochlear implant use, her scores improved tremendously. Now, we don't go to this patient and say, we now know that we prevented your chance of developing dementia or anything like that. But the patient is very pleased to understand that their cognitive load has been reduced and that they're able to perform these mental tasks better. And so it allows the patient to put real numbers to how the intervention is affecting their life. And it's very meaningful for that patient. So in summary, we've learned that a modern approach to hearing and listening evaluation should include more than an audiogram. It should also include quality of life, speech and noise testing, and cognitive skills. This comprehensive view of evaluating listening ability helps us to differentiate our practice and meet the needs that are top of mind for our patients. And finally, cognitive screening is not the same as diagnosing and treating, and that's okay. We can still participate in this screening and have a meaningful impact in the lives of our patients. And so with that, I'm going to go ahead and turn the time over to Dr. Davis, and we'll let her take it from there.
Thank you so much. That was fascinating. I love hearing that. I am in a private practice in Austin, Texas. So I purchased my practice about 3 years ago, and I've been using CogniView for about 2 of those 3 years. And so I've just taken some time to look at the trends and figure out the flow in my clinic, and I want to share kind of what it looks like to implement cognitive screening with you. And so just a breakdown of what my practice looks like. I really have the goal of practicing to the top of my license. If someone comes in with a hearing or balance disorder, I want to be able to diagnose and treat that patient. I do not like sending them somewhere else. If someone comes in with an ear issue, I want to be able to address that for them. So just to kind of introduce you to my practice, I've listed some of the services here for you. But since implementing cognitive screening in 2020, I think one of the biggest changes that I've seen is the referral sources, or where my patients are coming from. When I purchased the practice, the previous owner put a lot of funds into different advertising and marketing campaigns. And we wanted to look at what the top 4 performers were. And they spent a lot of time getting some Google reviews, which paid off as our #1 referral source. And we had a steady stream of referrals from primary cares that we actually rent space from. But we relied heavily on insurance referrals, and we also had some patient referrals sending their friends to us. However, just by implementing cognitive screening and writing a few more results and reports, sending the primary care doctors just what we were finding on the audio and the cognitive screen, we saw that our physician referrals increased to the #1 referral source. Patient referrals went up as well. The internet stayed the same, and insurance dropped, which I don't know about you, but I think a more quality referral is someone coming from a physician who trusts me, coming from another patient who trusts me, and coming from the website when they've seen 5-star reviews. The patient walking in the door is okay with paying a little bit more for that service because they've already have the trust walking into the appointment. I'm not really keen on insurance referrals anyway. But coming into 2021, I dropped all third parties and saw that my insurance referrals went down to 1%. So now physician referrals are still even stronger because I've started to nurture those relationships. I'm still getting some online referrals and patient referrals going up as well. But now what's happened is audiologists have started sending me patients. And so I had quite a few audiologists send for some auditory processing or cochlear implant evaluations. I have some that send just for cognitive screening. And so, becoming the leader in the community is really what I was striving for. And I'm seeing it paying off just by adding a few more services to the practice. Whenever a patient walks in the door, I want to know if I'm working with an ear issue or a brain issue. And the reason is because they both present with difficulty hearing and background noise. So somebody walking in, and it's the #1 complaint that we get, they say that they struggle to hear in background noise. Well, that could be because of their concussion, their traumatic brain injury, their auditory processing disorder. It could be just because of untreated hearing loss, but it could also be some memory loss as well. They all present the same way. So when someone tells me that, I want to know what I'm working with. And so what we did is we looked at the over 300 patients that we've screened their cognition, and we broke it into these 3 cohorts. And so what I found is 10% of the people coming into my office are complaining of difficulty hearing, but they don't have measurable hearing loss on the audiogram. So these are the folks that get recommended an auditory processing evaluation. We're going to initiate auditory training and maybe demo some low gain hearing aids. We're going to tell their primary care doctor that we did cognitive screening, and maybe we can find another underlying condition that could be contributing to that low cognition. 30% of the folks coming in have hearing loss, but normal cognition. And let me tell you, those are the ones that you want. They are the ones that we've been trained to treat. They're the happy patients, no matter what we give them. They're going to do fantastic. They have the cognitive ability to adjust to the amplification that they're about to have. They don't need auditory training. They're going to do fantastic with hearing aids or cochlear implants alone. Now, 55% of these patients walking in the door do not pass the cognitive screening the first time. And so that's kind of a big number. That tells me I need to take into account maybe some slow processing, some issues with the brain. I need to come up with a better treatment plan for this population because I think they've taken too long to get their ears checked out, and we're starting to see that increased cognitive load. Once I treat them, I'm going to test again, and I want to see if their performance improves. If it does, then I know that it was just an ear issue that was causing that low cognition. If it doesn't, then we're going to take a closer look at what else could be causing those issues that they're having. And let's see what happened here. There we go. This is the patient experience. I'm not going to go into this in detail until the next slides, but I just want to show you what it looks like. When a patient comes to me, we start with a communication needs assessment to find the diagnosis. From there, we create a treatment plan based on our findings. I'm going to educate the patient on other underlying conditions and comorbidities that could be causing them to struggle more than they expect. We're going to do more reporting. We're going to just keep the primary care involved, maybe send to some neurology, but I think that's the key to success with implementing the cognitive screening is that interdisciplinary care, getting those physicians involved, and we do follow up with this patient consistently throughout their journey. As far as the diagnosis goes, what I found, my keys to success, my recipe for success is just like Dr. Grizel said, the handicap inventory. We want to know what their motivation and how much their issues are affecting their day-to-day. We want to look at the speech and noise test to get a real world experience for this patient. And then once I have that, I want to know if it's the ear or the brain that's causing that problem. And then we're also going to screen for comorbidities because I really want to know what other underlying conditions they have. And it might not be a surprise to you, but a lot of our patients are suffering from other conditions as well. So really trying to narrow down what could be causing their problems. It's helpful to have these conversations. When we come up with a treatment plan based on our findings from that recipe, if someone has normal cognitive view scores and so they've passed, everything is in the green, this is kind of what we've been doing for years as we look at the audiogram, the severity of the loss, the pattern to determine number of channels. If we do an A&L test, we can recommend level of technology based on their acceptable noise level. We get to ask the patient, what do you want? Do you want Bluetooth, rechargeable batteries? Do we need to look at, are you a musician? Do you have tinnitus? This is the group that does really well with the technology that we provide for them. This is kind of what we've always done when working with hearing impaired patients, is if it's just their ears, we're going to have a successful outcome. However, when they do not pass the cognitive view, our recommendations get a little bit limited. We don't really need to go into different technology levels, different pricing, because based on evidence, the research that's been around since 2002 on best programming parameters for low cognition, we can assume that this patient is always going to struggle in background noise and will benefit for some remote microphones or FM systems. I want to implement auditory training to help train the brain on the sounds coming from the ears. And I put question marks by the slow attack release time and less channels because that's what the research shows us from hearing aids back in the early 2000s, but technology has changed quite a bit. So there is a little bit more research that we need to know the best fit for these patients. I'm going to get the patient's primary care involved, and I'm also going to talk to the family about best communication strategies now that we know there is something going on in the brain that is affecting their performance. This is the questionnaire that I give everyone, and they get to take it home with them, but this is where my underlying conditions come in. So everyone walking in the office, they're going to get asked if their short-term memory has decreased in recent years. No matter how they respond to that question, I'm still going to do the cognitive screen. I just know how much emphasis I want to put on that ear-to-brain connection. When the patient comes back and we have fit their hearing aids and we're testing again, if we don't see the cognitive performance get back up to where we want it to be, I will bring back this questionnaire and say, it looks like you haven't had your vision checked. You know, maybe we should send you to an optometrist, or tell me more about this social isolation. Of course, because of COVID, everyone's been feeling it, but do you feel like we need to talk to somebody about that? Or what most folks have is multiple medications. When's the last time you checked with your doctor about this list of medications? Do you think that could be having an effect on your memory? Because the ones that don't always get back up to normal, they do feel like they've been slipping, and they can self-diagnose some changes in their memory. And so as far as reporting goes, I do want to test these patients again before I send straight back to primary care or neurology, because wherever they go next, they're going to have to listen to some verbal instructions. They're going to have to be able to communicate with these doctors. And I want to make sure I've done everything to get their audibility up at least. So we're going to treat the hearing loss test again. And at that point is when I'm going to send that recommendation to either primary care if they have underlying conditions. If everything's clear and I know that they don't have anything else that can contribute, let's just go straight to neurology and get that cognitive workup. So in my clinic, we have a 60-day trial period with new hearing aids. And so, you know, state law gives us 30, and I push that to the 60 days. And so I bring my patients back for a graduation appointment. At that time, we go over the aided handicap inventory together just to see some improvements. We also retest the unaided and aided QuickSyn, and we see improvements there as well. And we're going to retest the CogniView. So all three of those go into that appointment to show how much we've improved their quality of life. At that point, we can reduce our return rate because we've proved that there has been benefit. Even if the cognitive performance does not get all the way back up to normal, you're pretty sure that you're going to see the handicap get better, as well as the speech and noise testing. So I want to share just what it looks like in some real world case studies, going back to that recipe for success, how I create treatment plans and what I'm talking to patients about based on those 4 ingredients. And so this is something that I see all the time. This is actually, when I was looking for different reports, it was really hard not to find something that looked like this. It's a 65-year-old man who came to me. He's had hearing aids for 3 years, just not happy with them and hasn't worn them. He actually feels like he's starting to lose his memory. Those were his words, that he felt like he was slipping. His handicap inventory is pretty high. That's a scale of 100 and he's at 56. In my clinic, we look at anything more than 12 is considered a handicap. And his speech and noise test, the QuickSyn, is at 7.5. More than 3 is considered a handicap in the speech and noise. On his CogniView, his memory is low. That number should be 77. It's just barely outside of normal. Everything else is within normal range. But what that shows me is that he is working harder than he should have to, that the increased signal to noise for speech and noise and that low memory score tell me that he is compensating for that hearing loss and just working harder than he should have to, is how I explain it to him, that increased cognitive load. In my experience, I've seen that the memory and executive function scores directly correlate. So when one is normal, usually at the retest, the other one will improve as well. So I have very high expectations for him that if we can just get him with a device that he's happy to wear, we're going to see a lot of improvements with the QuickSyn as well as his cognitive performance. Now, this is a 69-year-old female that was referred to me for cognitive screening. I do a full workup, even if they just want cognitive screening, but she mentioned to her doctor that she felt her memory was starting to go. Her handicap inventory is very low because she lives alone. She turns up her TV. She doesn't have family around, so she actually did not know that she had a hearing loss. Her QuickSyn score was 11.5, which is pretty high. And look at her cognitive performance. A general rule of thumb is we want to shoot for around 75 executive function, 77 memory, visual spatial should be 49. So she's actually okay there. But when you're an audiologist and you're trained like I was to look at the audiogram, you would probably be drooling over this lady. She's going to do so great. We're going to put hearing aids on, get the audibility up, and she's going to be fantastic. However, when you take into account that cognitive performance where it looks like there might be some mild cognitive impairment starting with her, she's actually probably not going to adapt to that technology as quickly and easily as we think she will. She's always going to struggle in background noise, and I want to start her off with something slower and more linear. I want her to have a cleaner, clearer sound, less compression, because I really need to make sure her brain can make sense of what the ears are hearing. And so taking that into account and not starting her off with really fast processing and lots of things to confuse her is really helpful to know about that cognitive piece. And then here is a 64-year-old male with pretty high handicap and normal cognition. These are the ones that we really like because they're going to do fantastic. However, this gentleman has had hearing aids for 4 years. He just doesn't wear them. And he doesn't like them. He wants something with Bluetooth. Batteries are a hassle. I don't know why. He just keeps putting it off because he can get through with his normal cognition. He can compensate for that hearing loss. But I sent out a mailer about an auditory training program that could help improve your memory. And he responded to that because he self-diagnosed himself with some memory impairment. However, he was very happy to see the results of the cognitive view, but we had a discussion about treating that hearing loss because it's presenting like memory problems because he's working way harder than he should have to. So he's actually enrolled in a study of mine, and he gets to try fast and slow compression. We're going to see which one is better for him. So he's going to do great as long as I can just get him something comfortable that he likes wearing. He's going to do fantastic because now he understands that connection with ear to brain. Our folks with the normal cognition, they can really fight through these hearing losses. So they don't usually come in sooner than later because they have the cognitive ability to fight through that hearing loss. And then lastly, this is a gentleman that came to me for tinnitus only. He denied any hearing loss. He didn't understand the connection between the two. His handicap of tinnitus was pretty high. He's a musician and tattoo artist. He said he had some social isolation and he's a little depressed that he's not performing since COVID. But tinnitus was really his only concern. And he still, after I showed him, was not convinced that he had a hearing loss. And so looking at his QuickSense score unaided was 3.5, and that translates directly to his low executive function. That number should be 75 and he's at 70. The other scores are all within normal limits. And so usually on the QuickSense, once someone starts getting outside of that 0 to 3 range, you start seeing a little bit poorer performance on the cognitive view. And so this guy is also working harder than he should have to. His tinnitus is getting in the way of his focus. It's actually ruining his quality of life. And so because I had to convince him he had hearing loss, we did a demo of some technology. And 2 days after he left with the demo, he sent me an email with all of these positive feedbacks, which you can read through that. But the biggest one was, I don't want to go back to the way it was before I came to see you. And that's just after 2 days of having some stimulation. I didn't even activate Zen in that tinnitus setting for him. But he wore the hearing aids for 60 days. He came back and his handicap went from a 40 to a 4, and his executive function went from 70 to 80 within normal limits now. His memory actually jumped from 90 to 99. So it's really hard to get a 99 on memory, and he did fantastic. But the best thing was how much we improved his quality of life, where sometimes patients come in with thresholds normal out to 2, normal out to 3. Their motivation is not quite there because they don't detect an actual hearing loss. He could get passed over and told to come back in another year. We'll just check again. Your discrimination is 100%. So treating sooner than later, we can hopefully stop the progression of any cognitive decline and get him into some technology sooner than later, and we can preserve this cognition. So how cognitive view improves audiology, I think it's all about the appropriate referrals and building up that medical professional network. With the disruptions in our industry, I really prefer to have patients coming to me from doctors who have told them where to go. They trust me. I think getting into that medical model of audiology is the way to go, because now we have appropriate counseling and clear direction for our patients, we get to talk to them about all these other things that are going on with them. And I think audiology is the place to start that conversation. We're just more nurturing. We have time to spend with these patients, and we can send them in the right direction based on what we're doing for them. You know, hearing loss is the #1 modifiable risk to dementia, according to Lancet. And so as long as we're treating the ears, which is a big piece of the puzzle, we can be confident when we send them on somewhere else that they're going to be taken care of. So coming up with those appropriate treatment plans based on the research and what correct technology would be with them, we're really going to reduce those follow-up appointments that fill up our schedule for those patients that we thought was such a great fit, but they keep coming back blaming their hearing aids for their difficulties hearing in background noise. Now we have a conversation to say, we've done everything we can with your hearing. Maybe it's something else is causing you to work harder than you should have to. And I think a big part is getting that number of that 30% of folks that have hearing loss and normal cognition, getting that number up so we can treat the hearing sooner than later before it starts getting into that cognitive decline state. So please feel free to reach out to us with questions if you want copies of the slides. If you need any more information about cognitive screening, we're happy to share that with you. And I think that's it.
but mankind won't be destroyed. The fact that you and I are working here today is evidence of that. but mankind won't be destroyed. The fact that you and I are working here today is evidence of that.
Hello, this is Dr. Joe Sakamura, Director of Centers of Specialty Care at the American Institute of Balance. Today we're going to be discussing and walking through some of the concepts that may make BPPV patients somewhat difficult to manage. We're going to be addressing the fact that most patients with this condition should clear 90% or better of the time with just 1.25 treatments. However, what happens when patients with BPPV can be recurrent or difficult to treat? So today we're here to address some of these concepts. We've got some wonderful information to share with you, some wonderful science. We are thrilled and happy that you're here with us today, and we will go ahead and get going here. We'll begin with just a brief review of the pathophysiology of benign paroxysmal positional vertigo. Remember, BPPV, benign in nature, meaning no damage is actually caused to the periphery or its innervation or central structures. Right? So the word benign, paroxysmal simply means that symptoms are rapid onset. Positional, meaning that it is provoked by changes in certain head or body positions, and vertigo meaning that you have this sensation, a hallucination of movement. So the pathophysiology, of course, we know that in BPPV, or in normal individuals, we all have otolithic organs that are responsible for sensing gravity and what's called surge, movement, acceleration in a linear fashion. So in BPPV, these otoconia, which are supposed to be located on the utricle, right, we know that BPPV otoliths are utricular in origin, so they're designed to be on the utricle. These are always sloughing off. There's a pattern of dislocation. They fall off, and in a normal system, they're absorbed into endolymph. However, in patients with BPPV, otoconia are dislocated into one of the three semicircular canals, which render that canal sensitive to changes in the gravito-inertial vector. So a canal, which is only supposed to be sensitive to velocity changes, now, in a sense, it becomes sensitive to gravity. Most commonly, this condition affects the posterior canal, and that's simply because of gravity. Gravity always works. Gravity always wins. So the most commonly involved canal is the posterior. However, you can have involvement of the horizontal or the anterior canal. Now, canalith repositioning, the treatment for BPPV, simply uses the pull of gravity to reposition or relocate these debris through both arms of the posterior canal and back into the utricle. The solution to pollution is dilution. So by putting the debris out of the canal, relocating them back into the utricle, where there's a more favorable metabolic makeup or a more favorable chemical makeup, more fluid, if you will, the fluid to crystal or fluid to otolith ratio is more favorable, the debris typically will dissolve or absorb and be carried out via endolymph. That's the process that all canalith repositioning is predicated upon. Where patients can become somewhat challenging is largely for two reasons. Number one, their biomechanical makeup can make it challenging for canalith repositioning to successfully be completed. Number two, the favorable chemical makeup of calcium deprived, vitamin D rich fluid, the chemistry is off. So the two concepts that we're going to be discussing today are some of the comorbidities and certain things that may make these patients more difficult to treat than we would expect. But again, you have debris that's designed to be on the utricle, making it sensitive to the pull of gravity. It's become dislocated from the utricle, and it's been relocated or displaced into one of the semicircular canals, where it must ultimately be repositioned back into the utricle. Remember, BPPV, benign paroxysmal positional vertigo, is the most common cause of vertigo. It's the number one cause of dizziness in patients over the age of 60 years. 50% of people over the age of 70 will experience this, but it can really occur in any age group. Remember, you can have BPPV largely in a couple of different ways. Number one, it's idiopathic. We're going to be speaking a little bit today on why idiopathic. We're starting to understand that some of these causes, particularly systemic issues with blood flow, arterial disease, and these kind of things, why these can be contributory. But this can be an idiopathic condition. This can happen secondary to otologic disease or disorder. In other words, secondary to something like a vestibular neuritis, or this may happen secondary to something like concussion. So one of a couple of different ways. So it makes sense if you look at the pathophysiology, right? Concussion or head trauma causes a chunk of debris to be displaced that's too large to be absorbed by the fluid. Something like a vestibular neuritis, which causes sensory neural vestibulopathy, can cause a disruption in the blood flow to the ear. Disruption in blood flow to the ear makes the fluid not readily available to absorb, right? The chemistry becomes off, or the utricle itself has reduced blood flow and more debris than can be absorbed is falling off. So this may occur in any age group. Typically in younger individuals, it's secondary to head trauma. This is only bilateral in about 15 to 20% of patients. However, if you have something like a concussion, you can have bilateral or multi-canal involvement. So you can have debris in the left and right ears be an issue. Greater incidence in women than men. We believe that this is migraine related. Remember, migraine causes all kinds of different neurologic symptoms and can have actually expressivity within the peripheral vestibular system. So we see a greater incidence really in all otologic disease and disorders in patients that have a migraine history, which is predominantly, again, female. Far too often in medicine and in healthcare, we refer to this condition as, oh, it's a benign condition. It's non-life-threatening, right? The patient should be fine. Maybe we can send them home with an exercise plan or whatever. But the reality of it is, this condition is only benign if you're not the one who has it. That's one of our mottos at the Institute here, our belief system. So this is a really nice study done by Roberts, Abrams, Lister, Gans, and team, looking at measures of health-related quality of life in patients that have BPPV. So we know, again, from Balatsouras and colleagues and things, that BPPV causes an increase in anxiety, an increase in depression, a threefold increase in fall risk. It's a really big deal. It's not a condition that should be pushed aside or the patient should simply be told that you're getting older, right? Our paper here shows that BPPV absolutely has a negative effect on an individual's health-related quality of life. We also know that treatment of BPPV improves these health-related quality of life measures. So again, yes, this is a benign condition. However, it's not very benign if it's making patients too anxious to get out of bed. It's not very benign if it's elevating depression or making them fear avoidant of movement. It's not very benign if the patient is falling and suffers a hip fracture, wrist fracture, head trauma, etc. So we've got to be very, very cognizant of this when we're talking about BPPV. The other thing that we've got to understand, that a condition like BPPV in some of the more recent literature, it costs not only the patient's quality of life, but also the medical economic system. In the United States, Jong and colleagues, who study a lot of the vitamin D factors related to BPPV, etc., they did a study that looked at and demonstrated that the cost of BPPV per patient to identify this in the United States is around $2,500, so $2,500 to come to as simple a diagnosis and create a treatment plan for BPPV. In other countries, this cost can be below $200. So we've got to understand as healthcare practitioners that the gold standard of treatment for BPPV is canalith repositioning maneuvers, clinician-directed maneuvers. It's not home-based Cawthorne-Cooksey exercises. It's not YouTube. So we've got to understand where these patients need to be and how we can rehabilitate and improve their quality of life most quickly. Okay, so let's take a look at some of the non-otologic factors that are associated with BPPV. Looking at these, many of them are actually systemic conditions that are related to changes in blood flow. Cardiovascular disease, diabetes, right? Atherosclerosis, arteriosclerosis, hardening of arterial walls, fatty deposits. These kind of things make it very challenging for blood to reach and supply the fine arterial systems that feed the inner ear. Right? Think of the utricle like grapes on a vine. These crystals are sitting. What happens if you cut off the nutrients to the grapes? They start to shrivel. They start to fall off at a rate that's more quickly than they would have had they had proper nourishment. So taking a look here, we know that if you influence blood supply to the labyrinth, you're much more likely to have BPPV. And further, the data is now showing that the more likely you are to have recurrent issues with BPPV if you have some of these comorbidities. So migraine, again, we know that migraine is bigger than just a blood flow issue, right? You're talking about release of neuropeptides, neuroinflammatory toxins, and these kind of things. But what happens with migraine is vasodilation, constriction, some of these kind of things. So stroke, transient ischemic attack, TIA, heart problems, all these kind of things that influence ultimately the blood supply and the nourishment to the labyrinth. So starting to look at this as bigger than just an otologic conditions, we know that in healthcare we're seeing patients with all of these comorbidities, particularly in our older adults and patients that are a little bit, in their 80s, 90s, right? We start to see more and more of these comorbidities. And then, of course, head trauma. If you jostle that vine full of grapes, you're going to have a certain degree of them fall off. But a lot of this has to do with maintaining homeostasis of the fluid mechanisms within the ear. We have to have an environment that's conducive to metabolizing calcium. Remember, these crystals are made of calcium carbonate particles. So we've got to have a system that is rich in vitamin D and deprived in calcium in order to have them properly absorbed. Otherwise, they're not soaked up properly, or there's an issue and they fall into the lowest point with respect to gravity, which in most cases is going to be the posterior canal. This is some really, really nice data out of the Balance Institute here, our publication, one of the largest cohort studies that exists with BPPV, right? One shy of 1,600, so 1,599 patients looking at the demographic and clinical characteristics, right? So we looked at a number of different parameters and these kind of things. Some of the most important of them are outlined here. So we know that hypertension, looking at that as an associated comorbidity, hypertension, blood flow issue to the ear, right? Concussion, migraine, diabetes, all of these absolutely influence the presence of BPPV, but also the likelihood that it's going to be responsive to treatment and that it's going to either recur or not. So taking a look at some of the age groups, the age ranges and percentage of these 1,599 patients, this is some really, really nice data that outlines some of the nice, paints a nice picture of the patients that are suffering from BPPV. We know that calcium carbonate is a big part of the issue with BPPV, and particularly the metabolism of calcium. And we also know, thanks to Zuka's classic work, that we can actually modify how quickly, in frogs, we can modify how quickly calcium is absorbed into artificial endolymph by changing the concentration of calcium. So we've deduced, or we've extrapolated from classic work and our understanding of the anatomy and physiology, that the absorption of calcium carbonate and the absorption of otoliths into endolymph is very, very dependent on the chemistry and the chemical makeup and the metabolic properties. So we started this, Zhang and colleagues years ago looked at a relationship between osteopenia, osteoporosis, and idiopathic BPPV, and what they found was absolutely there was a correlation. So we know that osteoporosis, osteopenia, obviously bone density issues and some of these kind of problems, these osteo or bone type of issues. So we started to understand, let's take a look a step further. Do we see decreased vitamin D levels in patients with BPPV? The answer to that question was yes. So we know that vitamin D is the catalyst, right? Vitamin D is responsible primarily in the body's fluid systems for absorption or uptake or metabolizing calcium. So patients that have vitamin D deficiency and some of these other kind of things, we're starting to understand that this plays a huge role in BPPV. So looking at patients that may be complex, that may be difficult to treat, that may not be responsive to treatment, or that may be recurrent frequently, so having BPPV come back, we've got to start looking at some of these systemic conditions or some of these non-otologic conditions that may ultimately be a player in this game. So this was some of the classic work, the earliest work in some of the vitamin D stuff. We're going to continue to progress and look at where this research has come and all of the exciting progressions. But this is some of the work that set the foundation for what we now know. Okay, so fast forward a couple of years. This was a nice 2019 article looking at impaired calcium metabolism in BPPV and kind of a review on some of these concepts. So again, we understand that these are calcite base, these are calcium carbonate material, and we know that a couple of different things are critically important in the metabolism of calcium. Obviously, calcium itself. Vitamin D is also a critically important player here. Also, estrogen. So this paper outlines very nicely that we have this extremely high prevalence of BPPV in patients that are peri and postmenopausal in females. And what do we know is strongly fluctuant in those populations? Estrogen. So sex hormones are critically important in the metabolism of calcium. We see a higher prevalence of impaired calcium metabolism in patients with BPPV. So again, what can we look at to restore impaired calcium metabolism with supplementation of vitamin D or estrogen? So particularly, the clinical relevance of this is huge. In patients that are coming back for recurrent BPPV, right? We treat them once, we treat them again, we treat them again, and they continue to recur rather than immediately looking at, oh, well, could they have a home exercise program? Could we teach them at home Cawthorn, Cooksey, Brandt Daroff exercises, some of these kind of things? Rather, we should start to take a look at some of these other concepts. Have they been worked up by an OBGYN and had their sex hormones looked at? Have they had a blood panel looking specifically at vitamin D? The other thing is, it's not safe just to give all of these patients with BPPV a ton of vitamin D. It's a fat-soluble vitamin. It can be toxic at high levels. So we've got to understand where the levels are, and they may actually need to do a loading dose, a mega dose of up to 50,000 around there IU, right? And then supplement that with 5,000 IU daily. This is a decision that the physician has to ultimately make, not the audiologist, not the physical therapist. But by bringing this to the physician's attention, right, we can help be a part of the resolution process. So it may be beneficial to have levels looked at before you actually prescribe a certain amount so that you understand where they are and there's different lab normative values, less than 10, less than 20, less than 30. Again, the data is suggesting that if they're at less than 20, right, per deciliter, we've got to take a look at what kind of things we can do to restore this calcium metabolism process with vitamin D and some of these other kind of things. Okay, and here's some of the newest work from Zhang and colleagues. So a lot of really, really wonderful research coming out of Korea, right? This study actually looked at a randomized trial, right, putting patients into control and treatment groups. And what they basically did was they looked at patients in two groups. They were all treated with canalith repositioning. One group, then they were followed for a year. Right? One group was put on a supplemental regimen of vitamin D and calcium. So I believe it was 400 IU of vitamin D and 500 milligrams of calcium carbonate chewable tablets. Right? They were taking this amount twice daily. The test group was. The control group was not taking any supplementation. And when they looked at annual rate of recurrence in a percentage, they found that patients who took this supplementation after repositioning maneuvers had a lower likelihood of recurrence. So this is another wonderful study. They actually looked at a certain amount. So they gave those amounts are listed, the 400 IU and the 500 of the calcium carbonate. So supplementation may be beneficial, and the research continues to point to this, may be beneficial when used with canalith repositioning to prevent the recurrence of BPPV. So anyone that's treated for BPPV, when speaking with them about recurrence, you should absolutely be giving them a follow-up plan of care. If this issue comes back again, we need to see you back at the clinic. But we also need to take a look with your physician. We need to take a look at what your levels may be, and should we consider some kind of supplementation. So this is absolutely huge research, wonderful data coming out of Korea. And we're starting to really understand, get a clear picture of patients that won't clear, those difficult patients, the ones that aren't clearing, the ones that are recurring, or the patients that are going home clear and coming back and they're positive again. Taking a look at the bigger medical picture and some of these other kind of things, these other factors that may be at play. We've now talked about some of the non-otologic or some of the other factors that are systemic, some of the metabolic contributors to difficult BPPV patients, right? So understanding when there is a challenging case or someone that's difficult to treat, understanding all of the systemic conditions that may ultimately be influencing the ear. Because remember, the ear is very, very susceptible to any changes in bodily chemistry. So there are a lot of, we talked vitamin D, we've talked metabolism of calcium, we've talked about blood flow issues. Now let's talk about a little bit about some of the mechanical or biomechanical structural issues with patients that can sometimes get in the way of treating them effectively. So this is just a nice little picture of a patient that we treated, with her permission, of course, the picture of a patient that we had at the Institute. She was a young woman with osteogenesis imperfecta, obviously a bone development problem. So it just so happened that she also developed a horizontal canal BPPV. Now this is a little bit of an extreme example, so this is a spectrum. But many patients cannot be treated with traditional Epley maneuvers, where you hang the head off of the table and it's quite uncomfortable. But in a less severe scenario, patients with kyphosis, spondylosis, cervical or thoracic spine mobility problems, right? Anyone that kind of lives in this range of immobility, or may just be advanced in age, or may not have core strength and these kind of things, you've got to treat them. You've got to approach them different than you would any other patient. So this is she's actually doing a cervical vent in the picture on the right, and then she's sitting with Richard there in that picture on the left, just prior to her treatment. So we're actually going to show you a video of the way that we treated her in the next slide here. Okay, so a really nice video of this young lady, and you can see that he's treating her, not hanging her head off of the table, but in a fully supported manner, doing a modification of the supine roll test, and you're seeing ageotropic left beating nystagmus. You can't hear what she's saying, but she's just so sweet. She's saying, "Oh, I feel that's the spinning that I've got, that's the moving." So again, you can see how you have to fit your treatment or base your treatment upon the biomechanical makeup of the patient. In no world could this young woman do a traditional Dix-Hallpike test or do a traditional supine roll. So you can see how he's doing everything in a fully supported manner, and it's going to be the same thing with the treatment. So now it's a geotropic nystagmus on this side. The full story is actually she's referred to us by a neurosurgeon who believes she may have some type of a compression or some type of an issue that's causing this positional dizziness. But in fact, it was just BPPV. Notice how, again, he's treating her with fully supported, very, very comfortable maneuvers. So he's going to treat this with horizontal canal maneuvers, Apiani, Caisani, meeting her with her needs from a biomechanical standpoint. I can't stress that enough. That's why in all of our courses, when we train and educate physical and occupational therapists, everything is done in a side-lying, fully supported, very comfortable type of a manner. So he does a post-maneuver recheck, and she says it's not spinning. So he was able to clear her. But again, when you have a young patient like this, typically there's going to be some type of a comorbidity that predisposes them to having BPPV, osteoconditions, head trauma, some of these other kind of things. So again, you have a combination here of mechanical barriers that could be a barrier to successful treatment, but she's also got some of these osteoconditions going on. Right? Could she have vitamin D or calcium metabolism problems? Absolutely. And in fact, she returned to us for follow-up about 5 years after this video was taken. She had had a recurrence, so we treated her again comfortably, appropriately. So again, all patients are going to be somewhere on the spectrum of biomechanical limitation. That's why, again, you'll notice if you see anything on our website, on our blogs, that we always do everything in a very, very fully supported, comfortable manner. Do the patient no harm. Clear them as quickly and as comfortably as you can. To summarize what we've kind of discussed here, coming to the end, again, we've barely scratched the surface here, so this is just a nice little overview of the difficult patient. But statistically, better than 90% of patients should be clear with 2 treatments. That's not 2 visits, that's 2 treatments. So we've got to be looking at these patients through a lens of multi-specialty, interdisciplinary management. When you're looking at estrogen, progesterone, when you're looking at vitamin D, when you're looking at calcium metabolism, when you're looking at biomechanical limitations, we've got to understand the patient is going to be an N of 1. Consider systemic comorbidities, which may be contributory to limited treatment efficacy or recurrence. So we talked a lot about blood flow issues to the ears. Diabetes, hypertension, hormone, the ear. Remember, the blood flow to the ear is some of the smallest, most tiny vasculature in the entire human body. So consider these blood flow issues or these comorbidities which may influence blood flow. Also looking at things that may be correctable with supplementation. So we talked a lot about hypovitaminosis D, osteopenia, osteoporosis, etc. Again, canalith repositioning is a valuable tool not only in treatment of BPPV, but also differential diagnosis of central nervous system versus BPPV. Each patient is an N of 1. You're going to have to look at them as such from a biomechanical structural standpoint, but also from a standpoint of the systemic issues that may be contributing to difficulty treating them or clearing them, or difficulty getting them through or having them stay clear, so reducing recurrence rate. May need varying levels of assistance with treatment depending on biomechanical makeup. So you're able to see that with that lovely patient video that we showed you there. In conclusion, we want to thank you so much for attending and listening to our presentation today. Please take a look at dizzy.com for a ton of free the Dr. Gans blog with video case studies. If you'd like to learn more about our education program, our certification workshops, or our Centers of Specialty Care Practice Development and Support Program, we would be thrilled to speak with you about all the wonderful things that we're doing at the Institute and how we may be able to help you in practice. So thank you, and we'll talk soon.